And we're going to start from slide number 4 in the slide box. That's right. Oh, which must be my turn then.
It's your turn, yeah.
Okay. Just bring that up. And then I'm going to share screen. There we go. Move it over and make that full screen. Good. Right. I just want to see if I can just change my... Okay, now I can have a chat window as well, just a little bit. Right, so what I have here is a pupil optic nerve section, pupil optic nerve head, and then optic nerve is in transverse section of an enucleated globe. At low power, I don't see a tumour. So remember in Diane's slides, this is how you divide up what you're talking about globes. Is there a tumour? Is there no tumour? I don't see a tumour, so I'm going to have to start from the front. So I'm going to start from the front and look here at the cornea. It hasn't rendered very well, but I can see most of 5 layers. There doesn't seem to be a large abnormality there. Angles are okay. Iris is actually touching the lens capsule here, which I'm not sure if that's an artifact or not. Ciliary bodies are okay. Posterior and vitreous space, I can see some cystoid change in the retina up here, and I'm just running my eye around, seeing the retina thickness. This is artifactual separation. Then suddenly the retina becomes very thick down here and thick around here on either side of the optic nerve head. And then as I run my eye around, the retina becomes normal thickness. So I think there's something happening around here and around here. Let's have a look. And if this is the optic nerve head here, then I'm probably going to be in the region of the macula either side. I don't know the exact cut. So let's have a closer look at what's happening in the retina here. So I think this is an artifactual separation, and the retina has become very thickened and it's really low density. So I wonder if it might be expanded because of edema. I just want to get my eye into what should be normal. I've moved too fast for it. Because if you're not sure, it's always good to look at a normal area for like an internal control and then look at the abnormal area. And that's what I'm doing here. So I can see retina with nerve fiber layer, ganglion cell layer, inner nuclear, outer nuclear, and receptors. Okay, so I've got my eye in for that. And then as I come around here, this is the abnormal area. And what's happened? It's become very thickened, but it's also become very lucent. There's spaces in between the cells. And I'm just going to start from the inner surface and move towards the outer part to be systematic. So the ganglion cells, although some of them are present, there seem to be apoptosis or fading away. They become very eosinophilic looking. Then this nerve fiber layer has become very fluffy and rather degenerate looking. There's disruption of the inner nuclear layer and outer nerve and outer what's that called? Not nerve fiber layer.
Lixiform?
Lixiform.
Yes, that's the one. So disruption here. So something has occurred to disrupt the inner layers of the retina, because I can still see the outer nuclear layer and the receptors seem to be intact. let me go and have a look on the other side. This is the optic nerve head. I can see the optic nerve fibers coming out here, artery vein. Let's go and have a look on the other side. And I can see, look at this here. So this is the nerve fiber layer. It looks rather vacuolated and rather edematous looking. The ganglion cells have become lost, and many are atrophic or lost. And the inner nerve fiber layer has also become, there's less cells than there should be, whereas the outer nerve fiber layer looks okay. So something has damaged the inner layers of the retina. So I'm thinking, could this be a vascular cause? Something that's caused preferential damage around the area of the macula close to the optic nerve head. Could this be an ischemic event such as a central retinal artery occlusion? Let's go and have a look at the central retinal artery. So when that renders, so optic nerve, coverings of the nerve. Conveniently, it's been put in transverse section. So we have retinal artery and vein in the center. And as we zoom up and have a look and see, because I want to see if there is a thrombus or an embolus or even a vasculitis causing a subsequent ischemia to the retina. And here I'm having a look at here. I don't know if this is, possibly it could be a thrombus, I'm not sure. So I see red cells and I see a bit of a fibrin web joining them together. It's not rendering at the moment, it's coming. Here we go, I won't go too close. So the light pink material probably would be fibrin. There's some nuclei in here, maybe of white cells, and there's a mat of red cells. So I wonder if that might be a thrombus, not entirely certain, but the consequences in the globe that I can see are ischemic inner retina around the macula, compatible with the central retinal artery occlusion. Diane, what shall I add?
Yeah, so Amanda, can we go back and have a look at that lens? Because it wasn't quite right, was it?
Yes. Other things.
So
tell me about the lens.
Yeah, so the lens capsule looks a bit baggy, doesn't it?
It does. It's loose, and then we've got this little lens flopping around on the inside.
Yeah.
Yes.
It's like the cortex has gone. So it made me worry that there was some lens pathology going on as well.
Mm-hmm.
I do wonder that because those irises seem pretty firmly attached.
Yes. Do you think this is a sneaky eye?
I did wonder about the sneaky eye there.
Yes. It's on both sides too.
Yeah. There's no like macrophages though that are blocking the angle, so I don't think he's got phacolytic glaucoma.
Because the bagginess is clear, isn't it? It doesn't have that sort of flocculent material that we saw last week with the macrophages gobbling it up.
So in summary, we've got acute retinal necrosis with a possible blockage of the retinal artery, and CRAO was in the URL, but my differential diagnosis would probably include acute retinal necrosis from other causes like herpes. So team, how would we tell the difference between a herpetic acute retinal necrosis and a CRAO? So Juliana asked, is the iris, so we've got some questions. Is the inferior iris quite flat? It is kind of flat.
Oh, yes.
It is.
This one?
The other one isn't though. Yep. Is the nerve cupped? I think it's really hard to tell because of the way that it's been cut.
We're not quite into like the midsection of it. We're just at the edge. Yeah.
Inflammatory infiltrate. So people are asking my my herpetic question. Inflammatory infiltrate. That's right. So a herpes infection would attract an inflammatory infiltrate. The acute retinal necrosis would be full thickness. Yes, it would be. And the other thing, of course, is the herpetic inclusions. So good answers there from everybody, including Nishan, who said it, yes, it will be full thickness, and there will be signs of inflammatory cells as well. I've just received a text. That was me going ping in the background there.
So no inflammatory cells in this one. So it was, although your eye is attracted to look up here at this thickened wiggly part, I think the best areas for seeing the necrotic changes are actually on the inferior side down here when you're looking at the slide yourself.
So yeah, this is an unusual slide because we don't get these as histologic specimens. All right, so I think I don't have any more learning points from this. Do you, Amanda?
Have we been through all of the things? You've done the differentials, special stains.
Special stains. Yeah, I would comment in particular that there was no evidence of granulomatous inflammation around the central retinal artery because we don't want to make sure it's not temporal arteritis.
Yeah, vasculitides, of course.
Why was it enucleated? That is a good question. I don't know why it was nucleated. I suspect this is another of these ancient post-mortem eyes where people died of another cause and then people went, oh, we'll just whip that eye out and pop it in our collection.
Yeah.
Could you comment on the retinal nerve fibre layer, whether it's gliosis or no?
I don't think it's got to gliosis yet. I think it's just got to dead.
Yeah,
Someone else wants to know central retinal artery, central retinal vein. How do you tell the difference? Yes, the artery is a bit thicker, but we hopefully would be able to see an elastin layer in the artery. So maybe that would be another stain we could do. And Nishan suggesting the differentials would be central retinal artery occlusion, central retinal vein occlusion, ocular ischemic syndrome, which I've not heard of, and small vessel vasculitis. So yes, any of the vasculitides, though we can't see vasculitis here because there's no fibrinoid necrosis and no inflammation and no granulomas.
There'll be inflammation
to see if there's elastin.
Yeah. This looks like the artery to me. It's got a thicker wall and it's got a muscular wall that's all together. Central retinal vein occlusion, so that's the vein. I think we'd expect to see a lot more hemorrhage, wouldn't we?
We would. It would be very much more congested and hemorrhagic. Yeah.
Red all the way around here with extravasation of red blood cells, which would correlate with what you see clinically, right? It's really hemorrhagic and red. And this one here would just look pale.
Great.
Good. Okay.
Just for a humorous moment, I was looking up the causes of retinal necrosis and I was typing in porn into the computer and I thought, no, I won't type porn into my work computer.
No. You'll get a visit from the cyber police.
That's right. Yes. So instead, I typed progressive outer retinal necrosis into my computer.
I know.
Okay, my turn. All right, so I'm going to share screen. Amanda's going to take over looking at the chat.
I'll monitor the chat. I thought you had to get the word
from Path Presenter.
Yes.
Okay, come on, pop up. Here we go. Okay, so here we have a globe, and it appears to have a mass at the back. It's a kind of pinky mass associated with hemorrhage, so it may or may not be a tumor. We'll go and look at that. The anterior part of the eye, the cornea looks normal. Here we have the angles, which are quite narrow actually, but appear to be open. The front of the lens is corrugated. I'd have to go and check to see whether that was an ectropion. It may or may not be. Ciliary bodies look all right. There's a hole in the retina here. That's a bit interesting. There's separation, which may well be artifactual here, but here there's separation by hemorrhage and there's a mass at the back. There doesn't appear to be a cup. However, the optic nerve does not show the flaring waist and thing out of the back here. And the meninges look a bit baggy, so I'm a bit concerned that there is in fact optic atrophy here. let's start by looking at the mass. Okay, so when I look at this mass, first I think about where the position of the mass is, and I can see that here is the choroid, and the mass appears to be subretinal. So we've got probably the RPE here, we've got Bruch's membrane, and it's kind of in the region between Bruch's membrane and the RPE. And when I get closer, what we have is a whole lot of fibrous tissue. Okay, so we've got vessels and fibrous tissue. We've got the retinal pigment epithelium probably here, and then we've got a retina that is highly disorganized. We can see that there's lots of scarring in the retina itself here, with some cobwebby gliosis and disruption, particularly, probably this is the outer plexiform layer, the outer nuclear layer. These might be ganglion cells. I'm not sure, I've not looked closely here yet. But yeah, these are probably ganglion cells in a nuclear layer. Outer nuclear layer is completely disrupted. And as we move along here, we've got a large amount of hemorrhage, which is lying underneath the retina.
How can we tell the difference between hemorrhage and exudate?
So hemorrhage has got red cells in and is bright red, and exudate is smooth and pink. Yeah. So we're dealing with an area of scarring in the posterior retina, something as anatomic pathologists we aren't expert in, because these eyes don't come out. So let's look here. Yeah, there does appear to be some optic nerve atrophy. Let's look here. It's the ganglion cells. So there does appear to be some ganglion cells, though they might be decreased in number. So I'm not ruling out glaucoma just yet. We'll go and have a look at the anterior eye. So we've got something that looks like this disciform scar here.
Could you explain scar a little more? What's
Sure.
scar?
So scarring is a healing response where the normal tissue is not replaced. So often in soft tissues, scarring is a process of fibrosis, where we get fibrous tissue and blood vessels, often starting as granulation tissue, laying down of collagen, and then contracting and forming a dense collagenous mass. Think of a healing scar after a heart attack. But in the brain tissue and the retina, scarring is gliosis. So we get replacement of the normal structures by proliferating astrocytes and their processes. So that's what gliosis is, and that's another form of scarring.
So is this scar a gliosis scar, or is it a fibrous scar?
We've got a combination. We've got actually fibrosis happening here beneath the retina, but we've got gliosis happening in the retina. Now, I know that the people who are online with us, Amanda, know much more about disciform scars than we do. So do you think one of you would be able to give a 1-minute introduction for us pathologists about disciform scars? I'm going to choose, is anyone volunteering? Nishan, are you going to volunteer? She says, poking him.
I would have volunteered Nishan as well.
Or you can type little snippets of information into the chat box.
Why are we getting this fibroblastic proliferation and reactionary fibrosis of the retinal pigment epithelium? Because this is the process that's happening here.
So, how is this different from age-related macular degeneration? Because we never see globes from these things.
No, we don't. So this is disciform degeneration of the macula. Why is this happening, people? Tell us why this is happening. I don't know anything about this. I'd have to look it up on iWiki, which I might be forced to do if you don't tell us about it.
Well, I presume this is
degeneration, isn't it?
Yeah, I would presume this is a result of like end stage wet age-related macular degeneration. So they would have developed a choroidal neovascular membrane which would have bled and caused subretinal and intraretinal fluid. And then that membrane eventually formed a fibrous disciform scar.
Too much vascular proliferation of the choroid here, Diane?
Oh, can I tell?
So Lucy's given us a plausible pathogenesis.
And we call this, and clinically we call it the type 1 choroidal neovascular membrane, because most of it's under the RPE.
Certainly is.
Yeah, I can't
Just
see
looks like regular choroid though.
regular choroid, yeah, and all the proliferation's probably here
Within the scar.
within the scar, yeah.
There's blood vessels within the scar.
Yeah.
So,
So maybe the scar's replacing that. And probably the destruction of the macula is related to why we've got atrophy here of the optic nerve.
oh, less signal going through it.
Yeah, so that all the stuff's dying off.
I expect this is another one of those autopsy eyes.
So this, I do have the history on this one, because
Oh,
this
do
is
you?
one of the ones that I put in. And it says here, so this is from the 1970s, and it says, in the 1970s, disciform degeneration of the macula with secondary vitreous hemorrhage, which this has. There's a bit of vitreous hemorrhage here. Mimicked in this case melanoma, and it came out as a query melanoma.
Oh, come out for, yes, tumour eye,
Yeah, tumor eye. Yeah.
but not tumour. Okay, good and bad.
I think it's just a really nice demonstration of the pathology, isn't it? Right, are there any more questions on the chat about this one?
So Chris says they were thinking ARMD too, but couldn't find any drusen.
Oh, drusen. Okay, yes.
Yes. Are drusen necessary? And I was wondering, could this be those that like diffuse soft drusen, like the basal linear deposit? I don't know. I mean, out here,
I can't see drusen either.
it looked okay.
Yeah. I'm just having another look, but no, I can't see any drusen. Oh, the retinal hole. I think this might be artifactual, because it's kind of curving away and down. It's probably just not in the section rather than a real retinal hole.
So Jess thought there might be some on the inferior retina. Are we in the right place? Posterior or anterior to the equator?
I can't remember.
Just trying to thought it was posterior to the equator in the inferior. So if you keep going down,
Yeah.
Sub RPE, maybe that bit. It's kind of like it's just beneath RPE and Brooks,
At the top.
above the choroid.
So, all right.
Oh no.
It has separated off, hasn't it? I'm in the right place. No, I couldn't see any convincing ones. This vessel looks horrible.
What if that's choroid?
Yeah, that
If
looks
you go to the top,
yeah.
you go up a bit more, the other way.
You mean?
Yeah, so there was one bit that looked like drusen, but keep going back.
It's got proof to where I was previously.
Yeah. Is that a bit of drusen, or is that too fragmented?
Oh yeah, that's probably a drusen.
Oh yeah.
Yeah, spotted one. Well done.
One
In the
drusen.
right place.
One drusen in the right place. Yeah. Is this another one? Maybe this is another one. Maybe I'm getting my eye into them now. There we go. A few drusen. Pretty subtle though. Okay. Good. All right. Next case.
Nope. That'll be me.
And then we'll take another break.
Yeah. Yeah, stop. Oops, I have to log in again. That's right, auto login. Share screen. Share screen. Share. Okay. Oh, I did all the ones with the tumours, so they're easier.
Lucky you.
Well, of course, you see, we see tumour eyes, but we don't get enucleated non-tumour eyes. So. Okay, so we have a pupil optic nerve section of an enucleated globe. I can see a tumour.
Yes.
I think this is an artifactual wrinkle and disruption. So located in the vicinity and involving the ciliary body, I can see a brown pigmented mass lesion. And what else do I see? That's what I can see at low power. I can't see any episcleral extension. And the angles, this one looks rather closed or squashed together, and there's a strange brown pigment in the angle. And if I look at the opposite end, there's also brown pigment up there. And this iris looks particularly brown on the anterior surface. So first I want to look at the tumor, and then I want to look at what may be associated with it. So looking at this, we have some hyalinization in the ciliary processes. So I think this is most likely to be an adult. This tumor seems to be detached. The section is probably not quite right, but I think it's associated with ciliary body pigment epithelium. And this is a tumor expanding the ciliary body. It's brown pigmented. Better go have a close look in here. Now, probably these cells are a combination of cells that are making the melanin, melanocytes, and cells that have gobbled it up, melanophages. Often melanophages are the really dark ones. So I'm going to look at some of the more lighter colored ones that I can actually see some nuclei of. It's a bit difficult actually. Some of these nuclei, I want to know, is this a melanoma? The other thing I was thinking, is it a melanocytoma? Because they're also very densely pigmented. In real life, what I would do, and this comes under the special stain section, is I would bleach it. I would bleach it so that I get rid of the melanin so I can see what the cell nuclei look like. So it could be a melanoma or melanocytoma. And then I'm going to look at the consequences of this tumor. So the iris, if I come around, so that's the normal posterior pigmented epithelium, I come around the pupillary margin, there appear to be numerous brown pigmented cells that are very spherical in shape. And these have the shape, to me, they look like they're probably melanophages, so macrophages that have gobbled up excess pigment. And this would cause heterochromic iris, particularly on this leaf of the iris, whereas the superior part doesn't have so much anterior pigment. So iris heterochromia, pigment in the anterior chamber. A lot of pigment here. This could be a combination of melanophages and or malignant melanoma cells. And as I come around and I look here at lower power, I can see that the trabecular meshwork is full of these melanoma or melanophage cells. So I suspect that we would have blockage to the outflow of the aqueous here in the trabecular meshwork. And is this true of the other side as well? Because I remember seeing some dark pigment at low power. Again, I can see the pigment cells in the anterior chamber loose. And they're also in the trabecular meshwork, although, I don't know, there's probably the canal of Schlemm there, which is not completely blocked, but I can see pigment in the trabecular meshworks. This is probably comes under the category of, if we call this one a melanoma, then it would be a melanoma lytic associated glaucoma due to trabecular meshwork outflow blockage. What should we add to that, Diane?
If we're calling it a glaucoma, we should pop to the back of the eye.
Yes, we need to find evidence of It's not the best section of optic nerve, I must say. However,
and often I think if it's an acutely, lytic melanoma, we wouldn't get the acute changes in the posterior, sorry, the chronic changes in the posterior, because it might cause a more acute glaucoma, but it's definitely always worth commenting on it.
Yes, I don't see a cup here. Don't see a cup. Now this narrow part and then wide part is because we haven't cut through the central part of the optic nerve. So because we don't have the central retinal artery and vein going through the posterior part here. So I was looking to see if there was atrophy of the nerve, but I can't really comment on that in this section, but I can't see a cup.
Juliana's asking, how would you differentiate this from pigment dispersion? So pigment dispersion wouldn't have the melanoma present, Juliana. And is this an open or closed glaucoma? Well, technically it would be an open glaucoma, even though the melanoma on this side is kind of pushing the iris forward. I think on the other side, it looks open. Yeah.
Yeah.
It's open-ish.
Open,
right? Open-ish. It's kind of open slash close. I don't know. It's pushed forward, isn't it? It's a bit interesting. It technically should be open, but this is a bit closed looking. So the question I want to ask the team here is, we've got melanoma lytic glaucoma, related glaucoma. Why might this melanoma be lyticking? Why is it breaking down like this? I can think of two good reasons. One of them is idiopathic, and one of them might be due to treatment. Okay, we've got some suggestions here. Iris rub. Yeah, it could be rubbing against the iris. An immune response. We could, though we don't see that. I was thinking of two other things. I was thinking of maybe it's undergone like some ischemic event. And the other thing is maybe it's had some radiation, post-radiotherapy someone's done. So if I saw this as well, I would definitely go and look for features of radiation in the eye and positively or negatively comment on them. So if a melanoma has had radiation, you can get melanoma lytic glaucoma. What might you see post-radiation, team? Amanda, have you ever seen a melanoma post-radiation in an eye?
No, not recently. They're not commonly taken out.
No, I've only seen one occasionally. And so we would see necrosis of the melanoma. And the reason the only reason I've ever seen them post-radiation is kind of when the radiation's failed and they've grown back. I missed the trabeculectomy. What's a trabeculectomy? Oh, trabeculectomy, yes. Yeah, sorry. Yeah, that could cause post-treatment glaucoma too.
I think it just might say in the information trabeculectomy, but I didn't know if it was in this slice.
What does the info say?
Yeah.
Just says trabeculectomy, but it might not be in this slice.
Is there a trap superiorly? I don't know.
No, there's a trab. There's a trabeculectomy superiorly. That's
a trabeculectomy. Okay, so this isn't a trabeculectomy. Yeah, this is a whole eye. All right. So, what was I saying? Yes, so it's always important to look for the change of radiation. The melanomas I've seen have been taken out because the radiation's failed. So we've usually got an area of necrotic melanoma surrounded by vital melanoma, live melanoma. And then we get the characteristic changes of radiation in the surrounding retina, which are gliosis, vascular changes with prominent endothelial cells and thick walls in the vessels, and inflammation, as well as, I've mentioned gliosis, haven't I? Yeah. So always comment on that. If you have a melanoma that you think might have been treated, have a look for the radiation changes. What other radiation changes do you get in the eye, team? You probably see them more than we do.
What happens to the cornea?
Cataract.
What was that?
Cataract, get cataract
Oh,
in the
yes.
eye. Yep. Post-radiation. What else do we get?
Edematous
Yes,
retinal.
retinopathy. You get neovascularization, retinopathy at the back of the eye.
Okay, cotton wool spots, neovascularization. What's HB? Sorry.
Hemorrhage.
Hemorrhage.
Hemorrhage. Yeah.
Okay, good. So you're pretty well up with all that clinically, so you would be able to apply it histologically. Right, should we take our break?
Yep, sounds good.
5 minutes.
Okay.
That's going
Come
to be
back at
12:46 for us all.
Yes.
I'm going to have.
cup
Oh,
of tea.
I won a lecturing award. They decided
Oh,
I was best lecturer this year. So the students gave me a prize, which I'm now opening.
okay.
The chocolate, I saved it for today. There we go.
Oh,
I get to
what a
have
good
some-
idea.
Yeah.
We all have to go and get our own, but you can virtually share.
Yeah, I will stop the recording now.
Okay, see you soon.